Hi guys, this is a bit of an overview of COPD and respiratory failure. COPD can be caused by a number of lung conditions, but the two most common are chronic bronchitis and emphysema. Chronic bronchitis manifests as an inflammation of the bronchiole in the lungs and excess mucus production, and that inhibits the oxygen and carbon dioxide gas exchange. And emphysema manifests as damaged alveoli, which limits the flexibility of those membranes and also limits the gas exchange. Chronic bronchitis and emphysema may appear in the same person, creating COPD, but they may demonstrate slightly different symptoms. So a person may experience symptoms in either one of these categories to the right. Chronic bronchitis might show up as a blue bloater or an obese individual, and they might display cyanosis or blue skin or fingernails, bluish, not straight up blue. Maybe increased mucus production, hypoxia, hypercapnia, which is excessive CO2 production, respiratory acidosis, increased hemoglobin, increased respiratory rate, exertional dyspnea, digital clubbing, and cardiomegaly. An emphysemic patient may experience similar symptoms, but they might not have the blue skin. Maybe they'll have some really pink skin. They might display some pursed lip breathing, like that, because it's a little bit easier for them to breathe that way. They might show a barrel-like chest because of their rib cage being constantly pressed outwards by all of this air trapped in their lungs. Prolonged expiratory time. They might speak in short, jerky sentences. They might be anxious, and they might be very thin. COPD is most often caused by tobacco smoking. That's 75% of people with COPD. That's what it's caused by. It might also be caused by air pollution, alpha-1 antitrypsin deficiency, which is a rare protein deficiency, protein made in the liver, asthma, or any other lung irritants. And COPD is diagnosed mainly through pulmonary function tests, spirometry, where they blow into this tube, and that machine measures their O2 and CO2 output, and that'll diagnose it. They might also do a CT scan, a chest X-ray, or an arterial blood gas test, or an ABG, which is a group of tests that'll measure pH, or peripheral oxygen, peripheral CO2, and peripheral bicarbonate, and a number of other things, but those are the main things that we're looking for. And they might check the CT or the X-ray to see if anything else is going on, to see if there's any heart damage, to see if they can see through the CT scan where the damages are occurring, and things like that. And COPD is most often treated preventatively through vaccines that'll prevent respiratory infection, and that's just going to help the exacerbation, really, of COPD. They may also receive pulmonary rehab and learning how to manage their COPD through exercise and diet and breathing therapy. They might also receive oxygen therapy through a portable nasal cannula they take home, or maybe they'll be on a CPAP or BiPAP at night if they also have dyspnea, things like that. And rarely they'll receive surgery if there's a specific harmed area, or if they qualify for a transplant. Respiratory failure often occurs as an exacerbation of an already impaired breathing. And in my patient's case, this was COPD, but it might also occur if someone has nerve damage from a stroke or a spinal cord injury that causes them to not be able to not breathe, cystic fibrosis, lung cancer, chest injury, scoliosis, which might impair their actual posture and breathing, alcohol or drug overdose, ARDS or pulmonary embolism, and some sicknesses that might exacerbate it are pneumonia or the flu or some other pulmonary disease that worsens that breathing condition and makes it so they really cannot get enough oxygen. And this is manifested in signs and symptoms as hypoxia or decreased oxygen, hypercapnia or decreased carbon dioxide, cyanosis or that bluish tint, high respiratory rate, confusion, solemnness or sleepiness, syncope or fainting, losing consciousness, arrhythmias, or crackling or abnormal chest sounds. And this is usually diagnosed through pulse oximetry, and there's the picture below shows what that is, where they put a little pulse oximeter on the finger and it reads the oxygen and carbon dioxide output. It might also be diagnosed by an arterial blood gas test, or they might also do an X-ray or an EKG if there's some other suspected things going on, especially related to the heart. It's usually treated through, if it's chronic, through nasal cannula that they'll take home, have that portable oxygen. If it's acute respiratory failure, it's a medical emergency, so they are going to get something on that person that allows them to breathe in an emergency, and that might be a tracheostomy, which is more surgical, or it seems to be at my facility more often. They're going to ventilate them, which means they are most likely also going to sedate them, because it's a little disconcerting to be awake to have that put in. And also that patient might require muscle relaxants because the ventilator is going to breathe for them. It's going to initiate the breaths. It's going to control the volume. It's like a surrogate lung. And that patient might also get IV fluids. Eventually that patient is going to be weaned from the ventilator, and that means they will have to perform a spontaneous breathing trial, which is 5 to 15 minutes of independent breathing, and they might try that about 4 times a day and see how they do with their ABGs and everything else. And if they don't do well, they'll go back to the vent, or maybe some other assisted therapies. Some ways that they'll wean patients off, and it really differs by the physician. Some new guidelines came out that in respiratory therapy that are outside our scope, but it seems like every physician has their different approach. But what they might do is use pressure support ventilation, where the patient initiates their breaths and they receive some inspiratory pressure assistance from the ventilator. They might also get synchronized intermittent mandatory ventilation, SIMV, which is some breaths are mechanically initiated and some are spontaneous. And those spontaneous breaths might also be pressure support ventilated. So they might also receive a little pressure assistance for the breaths that they are initiating. And they might also otherwise receive continuous positive airway pressure, or CPAP, and that's spontaneous breathing with positive inspiratory and expiratory pressure. Or, and this is less common, this is a phasing out practice, but some people still see it, they'll receive TP circuit, which is intervals of independent breathing and intervals of ventilation breathing. And the patient is monitored for arousability, heart rate, respiratory rate, ABGs, and cardiac output to see how they're tolerating that. And failure is pretty common. It occurs in about 20 to 30% of ICU patients. And a lot of times, enteral nutrition will be interrupted during the weaning process because they'll pause it so the patient can actually practice breathing spontaneously. And especially if they're in between, are they going to take out the tube? Are they going to extubate? Are they going to intubate? But they'll often pause that to see how things go. So one thing that we need to pay attention to as dietitians, sorry, that's my dog, is the pH, CO2, and bicarbonate balance, because although if this is respiratory failure, if the patient is hypercapnic, high CO2, they very well might be experiencing respiratory acidosis if they also have a slightly acidic pH and a normal bicarbonate level. But we can also contribute to the outcomes in that CO2 production by we can help that by not overfeeding. The guidelines, the Aspen guidelines say that especially high carbohydrate intake can worsen the patient's condition with acidosis and excessive CO2 production. So we want to make sure that we are not overfeeding, and especially with obese patients, it's recommended to actually underfeed with adequate protein intake. Before we initiate enteral nutrition for a sedated, ventilated patient, we must consider their mean arterial pressure must be greater than 50 millimeters mercury, and that is because their hemodynamic stability impacts their ability to digest food, and they might not be able to tolerate it, and their condition might worsen if we feed them and they're not hemodynamically stable. We also want to check for GI function. Is there a short-term or long-term expectancy? Do they need an NG tube? Do they need a PEG? Is this going to be a while? There any other conditions requiring altered nutrition needs, like diabetes, their glomerular filtration rate, their skin integrity, do they have any wounds? Ventilation status, that means increased needs, increased calorie and protein needs if they're ventilated. Obesity, so higher protein, hypocaloric feeding. And also we want to consider their diprivan or propofol rate, because propofol counts as 1.1 calories per milliliter of propofol, and that's mainly from fat that allows the medication to be absorbed. That's a part of that medication. The Aspen guidelines recommend to initiate enteral nutrition 24 to 48 hours within the onset of critical illness, unless contraindicated, and this is for people who can't get their PO intake in otherwise. And parenteral nutrition is only considered when enteral nutrition is not feasible, but for low nutrition risk patients, we're supposed to wait 7 days and see how they do, if they're able to recover enough to have enteral or to eat. And for high nutrition risk patients, we need to initiate parenteral nutrition as soon as possible. We also need to monitor and evaluate the tolerance of that enteral feed, and oftentimes people will check the gastric residual. Most of the time, everything's fine as long as the patient's being worked up to it, and they might be on a bowel regimen if they are experiencing poor peristalsis. So most of the time this is okay, this is handled. But if it's at greater than 500 milliliters, then you might want to scale back on the rate and let them take their time passing that through. We also want to monitor the ABGs and the abdominal signs and symptoms, if they are distended, if they have hypoactive bowel sounds, which are not necessarily indicators for tolerance on their own, but they're something to pay attention to. My case study patient's name for the case of confidentiality is Mr. F. He was admitted on 1/15. He's a 62-year-old male admitted for shortness of breath. He has a past medical history of smoking for over 20 years. And he was initially given CPAP and nebulizer treatment to help him breathe, but his condition rapidly worsened, and so they had to emergency intubate him, and he met the criteria for severe sepsis. He was diagnosed with acute hypoxemic hypercapnic respiratory failure, so low oxygen, high carbon dioxide, as a result of an exacerbation of COPD because he had pneumonia. And he also had tachycardia, and so that's why in his treatment plan they included that they were going to do an EKG and do some cardiac tests. His labs showed that his blood was slightly acidic. He had a high carbon dioxide concentration and high O2 when he came in. The nutrition consult was received on 1/16, and at this time he was still sedated and intubated, and he was receiving a low dose vasopressor. And in my note, I wrote that he had a past medical history of COPD and smoking. He's been giving antibiotics, and he is NPO currently as they are waiting on my nutrition consult. His current propofol rate was 27.9 milliliters per hour, providing 737 kcals from fat from that propofol. And the EMR indicates that there was some discrepancy between his admission weight and his current weight. And I think probably because his admission weight was verbal. And his current weight, once they weighed him with the bed scale, was pretty close to his usual body weight from April. Sorry, I'm a sleepy person. And so I used his current weight for the calculations. He was unable to interview, no family in the room, but I did speak with nursing about his condition. They just confirmed the consult, no new information to report. He is on sliding scale insulin, Protonics, propofol, and normal saline. And the insulin really is because he's under such a high stress situation. Even though he doesn't have diabetes, he's taking steroids, his body is stressed out, so it's likely that his blood sugar is going to spike. So that's a just in case precaution. He did not have a documented bowel movement, normal bowel sounds. He had no skin breakdown, and his anthropometric data showed that he's 6 feet tall, 93.1 kilograms. His ideal body weight, 80.79 kilograms, and he's 115% of his ideal body weight, BMI 27.84. He's overweight. His estimated nutrient needs, I went with 25 to 30 kcals per kilogram because those are the recommendations used by this facility. That's their protocol, but it's also really close to his Mifflin St. George and his Ireton Jones, which is appropriate for the ICU and ventilated patients, and his Penn State equation, which is appropriate for ventilated patients. And so I felt like that was a pretty good energy appropriateness. And I didn't bump up any higher than that, even though the ventilator probably causes increased needs, because I really wanted to avoid overfeeding him and exacerbating the CO2 production. His protein needs were 1.2 to 1.5 grams per kilogram, and using his actual body weight. and those are a little bit higher because he is on the ventilator. And his fluid needs are 1 milliliters per kcal, and we'll see in the actual intervention, we actually lowered that a little bit. That's just our standard recommendation, 1 milliliters per kcal. But just for the sake of not causing any fluid retention, we lowered it just a teeny bit in the intervention. So his diagnosis was inadequate energy intake related to sedation, intubation, as evidenced by NPO status, patient on ventilator, and tube feeding consult. And all this was approved by my preceptor. The intervention was vital AF, and that's the enteral feed, goal rate of 65 milliliters per hour with 45 milliliters per hour water flushes, providing 1,872 kcals, 117 grams of protein, and 2,344 milliliters of water. And in total, this patient is getting 2,600 kcals because we're also considering that propofol intake. And we're going to monitor his tolerance, and patient will be at goal tube feeding rate within 2 days and show evidence of tolerance. That was our goal. I checked in on him on 1/18. I saw that the day prior, the vital AF was initiated at 40 milliliters per hour, increasing it by 10 milliliters every 8 hours. So he did get close to his goal rate, but it was stopped for 6 hours because they wanted to try ventilation weaning, and he failed. He had bronchospasms, he had increased heart rate, increased blood pressure, and we also saw that once they put him back on the vent, he's got hypotension, and so it wasn't lower than we could feed. It was still hemodynamically stable above 50, but it was a little low, so they were unable to diurese him, even though he's starting to accumulate a little bit of fluid right now. And we saw the patient is receiving propofol now at 33.1 milliliters per hour, providing 874 kcals. He had been without enteral feeding the past 6 hours. Nursing, I talked with nursing, they reported that he's tolerating the feeds prior to his weaning attempt. And when I talked with them, they resumed the enteral feed at 45 mils per hour when I was with them, providing 1,296 kcals, 81 grams of protein, and 2,075 milliliters of free water, with a total of 2,170 kcals. He's still receiving sliding scale insulin, Protonics, Solumedrol, which is a steroid that's going to increase his blood glucose, propofol, and his labs indicate blood urea nitrogen of 19, phosphorus 2.4, and glucose 164 milligrams per deciliter. He had a bowel movement on 115, is no wounds, and his diet order is the vital AF. He had no altered nutrient needs since I last saw him. I didn't see any weight changes. I didn't see any condition changes. So he's still on the ventilator, so his needs were the same. And he was diagnosed with inadequate energy intake as related to sedation, intubation, as evidenced by patient on ventilator, still advancing to tube feed goal rate. And this is at the time I saw him after he had failed his test, and we started him back again. His intervention was to advance vital AF to the goal rate of 60 mils per hour with 50 mil water flushes, providing 1,728 kcals, 108 grams of protein, and 2,366 mils of water. And that's a total of 2,602 kcals with propofol. And we said patient will be at goal tube feeding rate within 1 day and show evidence of tolerance. I checked in with him on the 23rd. So last time I saw him was the 18th, so it's been a little while. But we saw that on the 19th he had increased CO2, he was given Lasix, and his IV fluids were discontinued because He was starting to accumulate a little bit of fluid. They found that his ejection fraction was pretty darn low, and that's probably a lot of the reason why he's starting to accumulate fluid, and also because the physician for, I think, 3 or 4 days was giving the patient IV fluids while also giving them the water flushes, and that was more water than that patient needed. So they discontinued that. On 121, there was a 2.51 liter fluid imbalance. That he was given Lasix, and 5.17 liters were diuresed. He's on heparin for a suspected non-STEMI. On 122, his sedation was cut in half. He was on SIMV, so that's weaning, overnight, and he tolerated it. And his enteral nutrition was halted during weaning. He had a negative 4.85 liter fluid balance since admit. He was on 123 weaned on CPAP. He was extubated and still had a negative fluid balance. His chest x-rays showed that he has improved pulmonary edema. That fluid retention is getting a little bit better. And a swallow evaluation consult was ordered before we start giving him food of any kind, just to make sure that after all that time of being on the vent, he's able to swallow. And he was diagnosed with acute respiratory failure, hypoxemia, hypercapnia, and those first 4 are all things we know. But under organic heart disease, they discovered an MI, a heart attack, and a low ejection fraction, aortic stenosis, and that he will require a left heart cath after extubation. And they noted coffee ground appearing in G output, but they didn't notice any change in his blood labs, and so they didn't worry about that too much. Usually coffee ground output means there's a little bit of blood going on, maybe some sort of irritation in the GI tract, but as long as it's not impacting his labs, it's probably pretty minimal. Hyperglycemia secondary to steroids, abnormal CT chest scan. They put him on GI prophylaxis, and that's usually Protonix or some other BM assist, just to prevent some reflux. And IV fluids, but those were discontinued, and also moderate thrombocytopenia. My assessment showed that he was receiving 145.2 kcals from propofol, no weight change noted, that negative fluid balance, and the swallow evaluation planned. He was still on sliding scale insulin, Solumedrol, and Protonix. His lab showed a BUN of 33, magnesium 2.7, blood glucose is back to normal. His abdominal GI report was that coffee ground, NG output, no documented BM, skin was intact, on still technically ordered with a vital AF, even though that was halted and for the weaning, and we showed no weight changes, all the same deal with his anthropometrics, but his nutrient needs were changed because now he is no longer on the ventilator. So I lowered his energy needs quite a bit to 22 to 25 kcals per kilogram, and that's consistent with using other formulas like Ireton Jones and Mifflin St. George. And that ended up being 2,048 to 2,376 kcals per day. And his protein needs, I lowered them as well because he's not on the vent, 0.8 to 1 grams per kilogram, 74 to 93 grams per day. And fluids still at 1 milliliters per kcal. Diagnosed with inadequate oral intake as related to extubation is evidenced by recent patient extubation and swallow evaluation prior to diet advancement. The intervention was to advance his diet as tolerated, hopefully to PO. Will assess for supplement need at follow-up, and will assess for diet education at follow-up. And we recommend, our goal was to advance his nutrition therapy. On 126, I checked back with him again. I noticed on 124 he was on BiPAP, so weaning him even more. On 125, he had that cardiac cath planned for 126. Sorry, excuse me one second. I have a very nosy dog. So I did get to speak with the patient on 125, noted his PO intake was 50% since 124, so he's starting to get a regular diet again, and he denied any nausea or vomiting or recent weight loss from his usual body weight of 195 to 200 pounds, and that's consistent with his electronic medical record. He reported some chewing difficulties since he doesn't wear his dentures. They've never really fit him, and he thought that he might benefit from a mechanical soft diet with some chopped meat, so we put in that order. He denied any swallowing problems, but noted his hand tremor has been slowing his eating. It just shakes a lot. He reports he eats plenty at home and likes to eat steak, ribs, corn, microwavable meals, and some vegetables, most of the time frozen, and he'll steam them in the microwave, such as broccoli, carrots, and steamed vegetables. He doesn't use his stovetop or oven, but cooks almost exclusively using the toaster oven and microwave. And he denied any adherence to a specialized diet at home. He was unable to name any high-sodium foods, so he struggled to keep his train of thought also throughout the interview. He was giving a handout and educated on a heart-healthy diet because that seemed appropriate considering his cardiac history, and he didn't need nutrition education on the COPD portion per his report. And but what I really wanted to emphasize with him that would touch on a little bit of his COPD was that the low sodium portion to prevent any fluid buildup that goes along with his heart that would also impair his breathing. And he was also given strategies to reduce saturated fat and also taught how to read a nutrition label. And this patient was very interested in what I had to say. Sweet dude, no altered nutrition needs. His medications were sliding scale insulin, sodium edrol, and Protonix. Forgive me one more time. And his labs are potassium 3.4 and BUN 26. So those are slightly off kilter, but he had a BM on 125. His nutrition orders were a heart-healthy diet, also with ADA carb control, even though diabetes wasn't in his past medical history. He was diagnosed, or I diagnosed him with inadequate oral intake related to tremor and chewing problems as evidenced by patient report of slowed eating due to hand tremors and chewing difficulty with tougher foods. Our intervention was to start him on a mechanical soft cardiac diet, and I didn't mention anything about the ADA because his blood glucose is fine, doesn't have diabetes. It's really not necessary, but if they continue that, it's really fine because it's darn similar to the cardiac diet in terms of what our facility provides. And I decided we'd order an Ensure supplement to go with his lunch to help meet his calorie and protein needs because he's not really getting in a whole lot right now. And I'll provide further diet education as needed at follow-up. And the monitoring and evaluation was to consume greater than 75% of daily meals and 75% of supplements. On 131, I checked back in with him, and I'll kind of speed through these because it was a pretty quick visit. I just answered his questions. He's awaiting skilled rehab at Fry, and patient saw the physical therapy, and he's got plans for tertiary care. At this point, he received his cardiac catheter on 126, is just recovering from that. 68% PO intake. He reported that he's still having chewing difficulty because, for whatever reason, I don't know, he's still having trouble with dry meat, and said he has to chug it down with some water, some sauce, or things like that. He reported, same usual body weight, feels he's lost since admit, and his EMR shows that he did lose 26 pounds since he was admitted, and that is significant per Aspen guidelines. That's 13% in less than a month. He reported his hand tremors improving. He's been drinking his Ensures, and he recalls a good bit of detail from the last time we talked. I answered a few more of his questions about low-fat cooking methods and the benefits of fiber. He actually brought up fiber with me, and I told him all about how that can lower cholesterol. He is taking Protonix and prednisone, and so he's still on a steroid, but he's off the Solumedrol. No remarkable labs at this point, woohoo! And a bowel movement he had on that day that I visited him. He had a post-cardiac calf puncture site on his right groin, which was not really a significant skin breakdown, so didn't increase his needs. There's his nutrition order. His anthropometric data shows that now his BMI is 24.28 kilograms per meter squared, and so now he's at a normal weight, but we still don't like that he lost that much weight. A lot of that is just due to they kept halting the enteral feeds to try weaning, and so that's just out of our hands nutritionally. And also, when he started eating again, he wasn't eating a whole lot, so it slowed him down a little bit. But the supplement definitely helped him not lose any more. And his estimated energy needs, I put as 25 to 30 kcals per kilogram, and so that's back to that normal range because now he's of a normal weight, and I didn't need to lower them when he was still in that overweight category. And also, I want to promote a stable weight. I don't want him to lose any more weight. And that ended up being 2,030 to 2,436 kcals per day. His estimated protein needs 0.8 to 1 grams per kilogram, 65 to 81 grams per day, and his fluid needs 1 milliliter per kcal. He was diagnosed with inadequate oral intake related to tremor and chewing problem as evidenced by a patient report of slowed eating due to hand tremors and difficulty chewing tougher foods. And for whatever reason, they did not approve the mechanical soft cardiac diet switch. And so we recommended that again. And I talked with nursing, and we got that all sorted out. But it really should have happened because the MD doesn't have to approve a downgrade in diet. It should just happen. So, and the second diagnosis was unintended weight loss as related to ventilation and recovery, as evidenced by patient ventilated or intubated 8 days and patient report of hand tremors in recovery. And my intervention was that mechanical soft cardiac diet. Will continue the Ensure supplement and will provide further diet EDUs at follow-up, but I doubted I would see him again because he's probably going to fry. And his goals were to consume greater than 75% of his meals and his supplements and maintain his weight status of 81.2 kilograms. And I did not see him again, and I'm happy to say that he improved so much during his visit, and we also had some really good education that wasn't directly related to COPD because to some extent there's only so much I can do about that, and it sounds like he was eating okay at home. His COPD wasn't impairing his intake at home, but he they discovered while he was here that he had cardiac problems, and so then I was able to intervene at that angle and talk about some things that he had never talked about before. So it turned out that it was a really good thing that I was following him, and I'm happy to say he got better. So it was a successful nutrition support intervention. Here are my references. If you have any questions, let me know. The links to the articles to read, if they do not work, they just copy the title of the article name and paste it into the search bar at library.appstate.edu, and log into your AppState account, and you should be able to find them pretty easily. That's how I found them. So thank you.